Thank you all for being here, and I'm really honored to have the presentation today. So my presentation title is Meaning and Importance of Phenotypic Developmental Disorders Among Children with Disabilities and among adult disabled persons. Keywords in my presentations are, as you see, intellectual disability, mental retardation, developmental disability, and morphogenesis. So here we start from the case study. I first mentioned the phenotype. Phenotype is like the outer manifestation of the certain genotype constitutes a variable dependent upon the genotype and impacts of the surroundings. So when I had that research, in that research I was looking like the two similar but not the same subjects. That was phenotypic abnormalities and phenotype minor anomalies. When we talk about phenotypic abnormalities, phenotypic abnormalities are the disturbances in embryogenesis or morphogenesis which constitute the abnormalities such as malformations, deformities, disruptions, and dysplasia. That is important because when we talk further about the phenotypic minor anomalies, which are isolated from regular developmental aberrations and are constituted of anthropometric variants in refined structures, family heritage, or within particular ethnicities, and as such as belong to the field of dysmorphia. Those two fields of the research are not the same. They are very similar, but are not the same. So in specialistic literature, phenotypic minor abnormalities and anomalies have their titles, and they are separated. When we talk about PMA, we can not only talk about phenotypic minor anomalies, but we can also use various names for them, like minor congenital anomalies, minor malformations, or physical minor anomalies. And a considerable number of PMA is found in individual may direct us to the existence of a serious morphogenetic disturbance. This is very important. This sentence is very important because this is the base. We will see in the other slides, but this is the base of the whole research. So when I looked at the books and on net and on PubMed and everywhere, I found that the researches on that theme have been conducted in not so many places. They have been conducted in Croatia, in Zagreb. That was my second mentor in my postgraduate study, Professor Zlatko Roksandić and Dr. Jukić Jelka, and myself too. We made some kind of researches on that theme, but Professor Roksandić is the head and he is the main in those researchers. We did it in Croatia. We did it on the sample of children with developmental disabilities, with mental retardation, visually impaired children, hearing impaired, and as well as among the female patients with recurring unipolar depression. I also found in the literature that have been conducted in USA in the population of schizophrenic people, in Hungary, in Pest, among children with genetic syndromes and metabolic disturbances, and in the Netherlands, Amsterdam, among children with malignant diseases. So, it is very important to say that a number of epidemiological researches have found that PMA show a remarkably more frequent occurrence in cases such as embryonal developmental disturbances, major malformations, specific genetic syndromes, mental retardation, psychiatric illness, children's malignant illness, metabolic illness, and hearing loss. Those all are the really common syndromes for such PMA patients. Further, I want to acknowledge that by the means of identifying PMA, so phenotypic minor anomalies, it is possible to determine relative values of phenotypic abnormalities and phenotypic minor anomalies, which can indicate general morphogenetic disturbances, but also can be valuable guideline in diagnosing a specific cause of malformation. So here are the three means of identifying PMA, that is physical examination, correlation, analyzing, and anthropometric measurements. All those three means of identifying we were using in our researches. In this slide is shown that there is a list of 4 different research ways to find some important acknowledgement of identifying of PMA patient. So, as it says, as regards healthy children, wide differences in the average number of PMA can be found in literature. This is partly due to not having applied identical criteria, but the differences can be attributed to the limited specimen as well as also to various geographic characteristics. Here it said that it's also very important that is valued on the various geographic characteristics. I must say that when I did that research 8 years ago, I did it all by myself on 400 people. 200 of them were disabled persons and 200 of them were healthy population. And I used this Waldrop and Halvorsen lists to put all the examinated and examination information in the Excel. So first they mention Waldrop and Associates, then Waldrop and Halvorsen, then Mehes, and then the list upon Opitz. With the purpose of serving research, researchers have drawn the lists, as I said before. So, Waldrop and Associates have drawn the list of 18 PMA that can be manifested throughout the 6 bodily areas. So, when I did the research, I also examined by the Waldrop and Associates lists, and I looked them over the head, eyes, ears, mouth, hands, and feet. So I looked all the points on their body, as it mentioned here, and as it mentioned in the list. If somebody is interested, I have a list with myself here. I can show it after the presentation. Waldrop and Halvorsen list is modified version that has been put since 2008 to use in numerous researches. They have accordingly come up with a system of quantifying the number and severity for each individual examinee. That is very important because when somebody do the research upon this theme, it is important that it can be done on individual examinee, not in general, but individual examinee. So here are two lists. One is from Mehes and the other is from Opitz. So since more than 50 variants of morphogenesis have been listed in pediatric literature, the researchers have also been using the list of 57 minor anomalies chosen by Mehes. And list by Opitz suggested that the alteration occurring prior to or during organogenesis should be determined mild malformations, whereas those that manifested after organogenesis during phenogenesis be named like minor anomalies. And this categorization bears no important clinical meaning. So those two lists by Mehes and Opitz bears no important clinical meaning. But I put it in the presentation to mention them because they are here too. So further, I will talk about correlation between mental retardation and minor anomalies. So in the title, I said that the research was on the mentally disabled person. That means that was on the mentally retarded person. But the title is more appropriate if it is in their disabled person, not mentally retarded person. So when we talk about correlation, when we talk about correlation between mental retardation and minor anomalies, we must say that it is first confirmed in the Smith and Bostian study. And preponderancy of mental retardation ranges between 5.2 to 16.6 among 10,000 children. And results of the published research are shown that the children with mental retardation are higher occurrence and intensity of PMA. And it has been done in the area of 18 manifesting variants of physical minor anomalies. It is also important to say that each particular instance of recognizing and identifying the exact scale and severity of PMA can contribute to early and timely diagnosing mentally retarded children. That is very important because what that means in practice, if the dentist know in which areas in the body, or the most important on the head and in the mouth must look, he or she can find on those children, I mean mentally retarded children, more symptoms such as, I don't know, syndactylia. On the head, they have not only one turn on in the hair, like 2 or 3. They have ears not separate, but not distance, but separate, and so on. So it can be really contributing to early and timely. Oh, I'm always going to early and timely diagnosing those kind of children. Also, there seems to exist a common factor during early development that triggers a particular developmental disturbance and brings the occurrence of PMA. So what was the aim of this research? The aim was to determine to what degree the level of present disturbances is indicative of explaining the etiology of the basic disturbance in such persons. So, as I said before, persons with several more serious phenotypic abnormalities show a more complicated form of basic disturbance. It is of utmost importance to research phenotypic minor anomalies in disturbances which have suspectedly arisen as consequence of abnormal developmental process. So in those kind of person, we find abnormal developmental process. Not only IQ that is lower than in normal people. Further, we go with explaining that such anomalies can form a basis for discriminating persons with mental disabilities, as we said in the title, or mental retarded people from the healthy population. The research is based on separately analyzing minor abnormalities and minor anomalies with mentally disabled persons. Concurrent analysis. So this is a little bit of hard to understand. Even when I did the research, I was must have to look to analyze what that analysis means and so on, but it really is helpful when the research is done to come to a certain point of informations and the conclusions. So, a concurrent analysis of frequencies of morphologic developmental abnormalities and of values of the minor malformation average according to Waldrop and his associates will be carried out. So, we did that. I did it by myself, and I must say that I was pregnant at that time when I had the research on the population of mentally retarded children and persons, because their ages were from 6 to 64, and after, when I got delivered, I had the healthy population to examine, and my baby was still a baby, so it was a hard time, but it can be done for the ladies who has not children yet, who have not children, so please have a children. Yes. This is like a little bit of resting from the presentation. So we can go further now. The data is to be compared with the results of the healthy population, of course. And the following hypotheses have been put forward. So there is 3 hypotheses that is been put forward, and the first is clinical value of phenotypic abnormalities within a population is of far greater importance than evaluation of phenotypic minor anomalies in order to discriminate the research population with mental retardation. A separate analysis of PA and PMA within the research population with MR renders valuable new information of fundamental genetic disorder, which is impossible to achieve by the means of Waldrop's list of minor anomalies. And the third one is it said that by analyzing minor anomalies within the group of mentally disabled persons as compared to the control group, we can attain information, their correlation, and define the number of groups of children with mental retardation. So we talk here about the correlation, which is the most important in this research, correlation between mental retardation population and healthy population. When we talk about mental retardation, there are various of it. So we can talk about mild mental retardation and moderate to severe And third group of mental retarded persons are those with profound mental retardation. Now we come to the field of examination methods. So in diagnosis of mental retardation, we use the Book of Regulations on Founding and Functioning of Expert Evaluation Bodies. And the occurrence of minor abnormalities and minor anomalies has been studied within a group of mentally disabled persons and within the control group. So, who are mentally disabled persons? Mentally disabled persons are those with underdeveloped intellectual functions. God bless. In this study, they shall be further referred to the 10th International Classification of Illness and Injuries, which is further developed and improved by the Nuremberg Code, as we will see further. But this is the base on which the research is referred, or has been referred. According to the level of IQ, there are 4 levels on insufficient mental capacity. So those levels of insufficient mental capacity are mild, moderate, severe, and profound. They have different kind of IQs, as you see. So mild are the people and the children who goes to their schools, you know. And profound one are those who are in the institutions with a lot of symptoms and syndromes which we have been not put in the research. So, in this research, the persons with the mentioned levels of mental underdevelopment have been examined collectively. And the control group are the persons who, during obligatory physical medical examination, have not been evidented with the mentioned diagnosis. But, as I said, the persons with recognizable genetic syndromes have been excluded from this research. Because when you see those kind of people, they are like, really, some kind of them are not aware where they are in beds, you know, and it's really, IQ is so low, and it's hard to see them, you know, but yes, they are living. And I was really touched when I was in those kinds of institutions to see the people that are working there, you know, because they are working there, they are working with the whole heart there, and it was really so touching for me to see that. So, the examinees were to be given a medical checkup at 4 medical institutions in Rijeka and Kraljevica in Croatia. So Rijeka is the city where I've been studied. It is on the sea in my little country of Croatia in Europe. I don't have a picture, you know, I don't have a photo, but maybe one day we will see each other again and I will have it. Yes. And the examinees from the control group underwent a medical examination at the privately owned general practice doctor's office in Rijeka and at the Educational Institute for Public Health in Rijeka. So I went in all those 6 centers. 4 of them was the mentally disabled person, and 2 of them was for the healthy population. And for all of them, I have originals here with myself now. In all institutions, I have to have approval of the principals of the centers, of the institutions, and
this study was to compare the orthodontic treatment expectations between patients and their parents who applied to the orthodontic clinic of Gaziantep University Dentistry Faculty. At the same time, the demographic structure of the patient population of the region will be tried to be revealed with questions asked to the parents. A questionnaire used before was modified to measure patients' and parents' expectation. Questionnaire 10 questions and 3 extra socio-demographic questions. Questionnaire was conducted on 120 patients and 120 their parents. Patients aged between 12 to 18 years old, and the written consent form was taken from both child and parents. These are statistical tests for using analyses. Our questionnaire and distribution of study population can be seen in the tables. First question, at your initial appointment, what do you expect to? Second, what type of orthodontic treatment do you expect to wear? Third one, do you expect orthodontic treatment will give you any problem? It's about the side effect. Fourth one, do you think wearing a brace will be painful? 5, do you think orthodontic treatment will produce problems with eating? 6, do you expect orthodontic treatment to restrict what you eat or drink? 7, will people react to wearing a brace? 8.1, how long do you expect orthodontic treatment to take? About the duration. 9, how often do you think you will need to come for checkup? And 10, what did you expect orthodontic treatment to? This table shows that socio-demographic values of study population, level of education, job of parents, and monthly total income status of the family. Comparison of children and parents' answer to the question. It was significantly different for 1A question, 6, 10A, and 10C. Question about expectation had 3 major groups. First off, from the treatment itself. Second, from the treatment process. Third one, general information about possible side effects of the treatment. According to the results, a large group of patients hoped to wear their braces at the first appointment. Again, a large group of patients thought that they are going to have fixed orthodontic treatment. It was seen patients didn't have much information about possible side effects of treatment, while those with knowledge seems having not too much concern in this regard. The popular reason for seeking an orthodontic treatment were to have well-aligned teeth and have a nice smile as reported before. 30% of the patient expected pain, which was found to be really low. This finding was in accordance with finding that orthodontic treatment rarely causes pain or discomfort, but different from reported the most of participants expected pain with orthodontic treatment. When considering the number of patients who are not aware of the answer to the question, it may be said that patients don't have enough knowledge about the pain. When we look at the results in terms of patients' parent difference, it was seen that there is a general harmony in the answer given. To the question 1, showing a more impotent attitude than their parents, patients wanted their braces being fitted a while. At the same time, similar to previous study, parents are less anxious than their parents. They don't think that orthodontic treatment will restrict their daily diet. While the parents were sure about that their child will have his or her teeth well aligned, patients themselves. Unlike the reported results, before most of the patients think their self-confidence will increase as a result of orthodontic treatment, but the belief in the parents seems to be much more than the belief of patients themselves. Based on our socio-demographic results, it could be said that the education level of parents were too low. Accordingly, 10% of the fathers are unemployed. More than 50% of the family's monthly total income is similar to minimum wage. Within the limitation of this questionnaire survey, acceptation from the first appointment, possible treatment effects on eating habits, and the reason for wishing to have orthodontic treatment, patients and their parents have similar expectation from orthodontic treatment. Indeed, the low socio-cultural structure of the patient portfolio of the university hospital necessitates more detailed patient information with a simpler language. Moreover, if this questionnaire is applicable in the whole country, the result will be far from being regional. Thank you so much.
Thank you, Dr. Gorman. Thank you very much for your nice presentation.
Thank you so much.
We're going to have a 10 minutes coffee break, and we'll resume the meetings.